with PhD in Physiotherapy, Masters in Sports Physiotherapy, MSc in Psychology, MD in Acupuncture, PGDCA, FFIMT. With 18 years of academic and 25 years of clinical expertise. Sports physiotherapist in Scarlet Cricket Association and Club. Nodal Officer and Chairman for KUHS Examinations Wing. Examination External Panel Member for SRM University Chennai, MAHER University Chennai, Savita University Chennai. Doctoral Committee Member for PhD Scholars in Kerala University of Health Sciences, Thrissur. President of Chartered Society of Physiotherapy Teachers, Malabar Zone, Kerala. Recipient of Distinguished Academic Administrator Award by White Memorial Institution, Tamil Nadu. Awarded for recognition of outstanding contribution in the field of physiotherapy by MGM Physiocon, Goa. Recipient of Award of Recognition by Kerala Association of Physiotherapy Coordination, Kozhikode, for the research work done in PhD, honored by Mayor of Kozhikode. Awarded for significant contribution in the field of physiotherapy in academics by Net Institute of Physiotherapy. We warmly welcome you, sir. Now, I request Dr. Arun Mosi, sir, and Dr. Manish Srivastava, sir, kindly come over to the stage and occupy the seat as a chairperson for this lecture. Now I invite Dr. Vijay Selvan and sir to proceed with his lecture. I request Swati Kaswar ma'am to greet our honorable guest, Dr. Sandesh Sahalwal sir, with a token of appreciation.
ऊपर नहीं जाएगा।
Good morning all. Good morning. Morning. सब लोग जागे हैं ना? Yes. सोना ही रहना. सोना मत. Okay. So thank you to all the wonderful organizers, the committee members, for inviting me and having me here in this fantastic atmosphere to share my knowledge to what little I know. So I need each one of you to please ध्यान से सुनना, कुछ लेकर जाना, कुछ मत छोड़ना यहाँ से, ठीक है? ठीक है? Okay, fine. So today I'm going to talk to you about a very interesting topic. It might not be interesting to you because have you all heard about what is the posterior tibial tendon? Heard about? You know about its anatomy? Yes. So let me brief a little about the anatomy of what posterior tibial tendon is. So posterior tibial tendon is a very important muscle by which we are standing upright, we are walking upright, we are able to balance, we are able to weight bear. It's a very important component which is on the medial aspect of our foot. Okay, so we can compare this posterior tibial tendon to a hanging bridge. Okay, so it is so significant. The origin is from the posterior one-third of the tibia, posterior one-third of the fibula, along with the interosseous membrane. It travels down, goes into the medial aspect. It is the most anterior tendon of the inverters. It gets inserted into many components. When I say many components, please dhyan se sunna. Okay. It gets inserted into the medial aspect of the navicle. Gets inserted into all the three uniforms. It gets inserted into the second, third, and the fourth metatarsal. It gets attachment to the cuboid. It gets its minimum attachment to the calcaneum. You see where it is, the insertion. Okay, so you can resemble to the hanging bridge. The bridge. So the गाड़ी चल रहा है ना, वो तो insertion part है. So the originator goes to top है, hanging bridge का. So it plays a very important role in keeping our foot upright. Okay, it's very important. That is why we have an arch called as a medial arch, right? It's very, very important and very, very quite essential. Okay, so it is a component by which the weight transfer is very good. The medial component is stronger. As all we know that the weight bearing is only on the lateral aspect of the foot, not on the medial aspect. So the medial has to take the whole loading, shift it towards the lateral side, and assist us in the normal gait. That's the main activity of the posterior tibial tendon. Okay, clear? Sharp enough? Clear? Okay. So, what will happen in case if there is insufficiency? What is an insufficiency? Less of its activity. It should be sufficient. If it is insufficient, it will lead to a navicle to go down, it will drop down. It will result in flat foot. It will result in hind foot pronation. Hind foot pronation हमको नहीं चाहिए. हमको तो neutral चाहिए and mid supination चाहिए. Hind foot pronation नहीं चाहिए. Okay, to walk properly and for the normal weight bearing. So it plays a very important role, this posterior tibial tendon, in keeping our arch intact and to make us stand, walk. It's a very important component of the stand space. It is the initial plantar flexor. It initiates the inversion of the posterior tibial tendon. Okay. Only when there is initiation, we will try to propel and move forwards. So the people who are having flat foot, they will have difficulty in posture, the gait, etc. Okay, so this is the brief significance of this posterior tibial tendon. And one more significance of this tendon is this tendon. I am saying this tendon, right? It is around 14 to 15 centimeters long. And around this 14 to 15 centimeters long, nearly 7 to 8 centimeters of this tendon doesn't have a blood supply. It doesn't have a blood supply. It's very least amount of blood supply it gets. That is the area where it winds around the posterior aspect of the medial malleoli. It gets winding around, gets inserted into the medial aspect in all the bones. There is a navicle, uniform, metatarsal, the cuboid, and the calcaneum. Okay. I said there is a minimal or no blood supply. So what happens whenever we are doing? How many steps do we take in a day? We all walk, right? Yes. How many steps we take on average? A normal person. How many steps? Any guess? Anybody from the audience? I want someone to have a mic and please pass it on to the audience. I want it to be an interactive session, not a monotonous session. मैं आपका कोचवामी नहीं है, जो मैं बोलूँगा आप सुन रहे हैं वही नहीं है. आपका इंटरेक्शन तो मेरे को चाहिए, ठीक है? ठीक है? Please pass around one mic to the audience. Okay, right. So what I was talking about? It has the least amount of blood supply. How many steps we take? We take on an average of 6,000 to 10,000 steps in a single day. So what will happen when we do this inversion, eversion, plantar flexion and dorsiflexion? The tendon moves around the posterior aspect of the medial malleoli. So there is a friction of the tendon along the medial, malleolus, posterior aspect. There is a tunnel, right? The tibialis posterior is going into a tunnel. Okay, the same way with the peroneus. Peroneus longus medius, it is going into a tunnel on the lateral side. This is on the medial side. So what will happen? The tendon will go for a friction. It will start to degenerate. That is why this posterior tibial tendon insufficiency will be termed under the condition called as degenerative tendinopathy. It's termed under degenerative tendinopathy. Okay, because the amount of steps we take 6,000 steps in a day. 10 दिन में कितना होगा? 60,000 होगा. 100 days कितना होगा? More than lakhs and lakhs. So what will happen? It goes on degenerating. So it starts developing pain. Pain is the cardinal sign. If you have pain, if you walk 6,000 steps, you will reduce it to 1,000 steps. So what will happen to the muscle? The muscle will go for a disease atrophy. The muscle will go for a weakness. You will lie down, you will not do any activity, muscle will further go into insufficiency. That will lead to the navigator to go down, it will result in a flat foot. Then I said weight bearing should be on the lateral aspect of the foot. Here in the case of the flat foot, what will happen? The weight bearing will be on the medial aspect of the foot. So the weight bearing ground reacting on the body reacting on the ground, it will cause more impact over the knee joint. The patient will develop knock knees. Okay? The patient will develop knock knees. Genu valgus. Coxa को क्या होगा? Valgus. Whenever there is a genu valgus, coxa will become valgus. तो क्या होगा? उसका impact pelvic पे होगा. Pelvic का impact spine पे होगा. पूरा शरीर का posture, mechanics, spinal alignment सब कुछ उल्टा हो जाएगा. ठीक है? सिर्फ एक ही मसल है कारण. कौन सा मसल है? Posterior tibial tendon. ठीक है? Right. This is what I was talking about. This is the tendon. So this is what I was talking about, the hanging bridge. The apex is the point where it originates. The base is the point where it gets inserted. See how many connections it has. I told you, the cuneiform, the metatarsals, the navicle, the cuboid, the calcaneum. So many insertion points. Why? It is very important. The muscle is very important.
साइड से होती तो साइड में
Next one. Next one. I want you people to spend 10 seconds in reading this because I have told all these points to you. Just read it. Mind reading that number. The prevalence rate is around 5 to 15% of the people who reports to you with the foot pain. Okay? जो लोग आपसे मिलने आ रहे हैं फुट पेन के लिए उसमें 15% posterior insufficiency. ठीक है? And you can see what all deformities it can create. It can create a flat foot, forefoot abduction, calcaneus valgus, navicular drop, plantar drop, then fixed forefoot varus, supination deformity, everything will be resulting. Okay? So why? We need to take a very critical why because this is the most underlooked condition. This is the most underlooked condition. We don't easily perceive. So whenever a patient is coming to you with their foot pain, what do? You will give ultrasound, you will teach them heel raise exercises, थोड़ा knowledge करना और उसका exercise teach करना intrinsic foot muscle exercises. That's all. But you have to search for the cause. You need to know the cause before treating the condition because in your professional life you will be getting 60% of the cases pertaining to foot pain in your professional life. So it's very, very important to know the biomechanics, the pathomechanics associated with it. So we need to take action to prevent the progression. I told you it's a progressive degenerative condition. It keeps on progressing. We need to stop the progression, like pain gauge. It's not work. We have to block it like pain gauge. Then why does the PDT attest? That is what we are going to see. Then what are the best viable treatments? That also we are going to have an insight. So you can see here, I told you, right? The foot is flat, the navigator is dropping, there is a hind foot pronation, supination line. Okay, so this is the person we are going to see frequently. So among the student population, what I want you to do is, the next session when you are meeting at your college or wherever you are in the university, just try to examine your foot, all the students' foot, you will come to know. I assure that nearly 25% of the student population will have a flat. It may be either acquired, or it may be due to a degenerative condition, or it may be due to a weakness. So here you can see there is a excessive pronatory motion, right? The foot and ankle is very abnormal. So this is the patient. We are giving them the conservative treatment without understanding the cause of the particular condition. The patient takes treatment continuously over year and year, but it doesn't get improved. Why? Because we have not thought about posterior tibial tendon. We have not improved that particular condition. You can see many people with the same scenario. Okay, they would have taken 5 years of treatment, 10 years of treatment. We are not treating the cause. We are treating the symptoms. Okay, we have to treat the cause. So you can see here how the arch is getting obliterated, how the flat foot is affecting the whole thing. It is going into a pronation, right? This is what I was talking about. We take around 6,000 to 10,000 steps a day. The tendon is going into a consecutive degeneration, friction for every tendon is covered by synovial sheath. It is covered by synovial sheath. So whenever you get such condition, palpate the medial aspect of the foot behind the medial malleoli, the tendon will be enlarged. Why the tendon is enlarged? Because of the friction, the synovial sheath is getting irritated, it is getting inflamed. In due course, what will happen? Tendinopathy occurs. Whenever I say tendinopathy, the size of the tendon will be enlarged to accommodate. Right? It has to accommodate. Clear? So, simple example I will give you. Have you all seen a hybrid plant? Different breeds. They will cut, they will attach it. Then after some time you can see a swelling over the particular area. Why? Because it is not natural, it is unnatural. The same way, the same swelling will occur to the tendon because of the repeated movements and the repeated actions. Clear? So you can see this talo-tarsal mechanism. Talo-tarsal mechanism. What are the components of ankle joint? What are the bones which constitute the ankle joint? Lower end of tibia, the lower end of the fibula, and talus. Just talus alone, nothing else. Okay? Lower end of the tibia, the lower end of the fibula, and the talus. Okay? The talus is the only bone in our body which doesn't have any tendon attachment. It doesn't have any tendon attachment. It has only ligament attachment. Okay? People on the left, are you awake? People in the middle, are you awake? People on the right, are you awake? Yeah. People over there. I think everybody is not having any periarthritis. You can very well do a hyperprotection, right? Everyone raise your hands, take it to hyperprotection, please. Everyone. Jago. Okay, right. Clear. So you can see here how comfortably the talus sits on the calcaneum. Okay. There is a segment called as a sustentaculum talus. Sustentaculum talus. There should be a space, gap. It's a smooth space between the talus and the calcaneum that should be maintained. Whereas in patients who are having this flat foot, the subsyntagmal tali will be broken. There will not be any gap. So what will happen? The talus will go and rub the calcaneum. They will develop an intimacy. The romance will take place between talus and calcaneum. और romantic mood में हो जाएगा, तो friction हो जाएगा. Friction के बाद degeneration होगा थोड़े दिन के बाद. Just like after marriage, initially we will have a very good friction, then it will degenerate, then again friction will develop. Okay, same way this talus and calcaneum will go into a degenerative friction mode. Okay, so you can see how comfortably it sits. It's a normal joint. Talotarsal mechanism. It's very, very important, right? Now, एक और बात है. I told you about the ankle joint. Next thing is called as the CPU. What is CPU? What is CPU? वहाँ थोड़ा friction हो रहा है उधर. भाई साहब इधर friction बाद में कर देंगे. ठीक है. What is CPU? Central Processing Unit, according to a computer, right? Here, according to the foot, it is called as calcaneopedal unit. It's called as calcaneopedal unit. This calcaneopedal unit are the components of the foot except talus. Why? Because talus forms with the ankle joint, right? The remaining unit is called as a calcaneopedal unit. Okay, clear? Be relaxed. I just want you to look at me, nothing else. Okay. So I have told you, this talus is the bone which doesn't have any tendinous attachment. It has got more of ligamentous attachment. The foot is a very, very nice component. There are several bones, the same way as the hand, right? The hand has several bones. We have the carpals, we have the metacarpals, we have the phalanx. The same way here we have the tarsals, we have the metatarsals and the phalanx. It's very complicated joint. So many ligaments are there. Okay, that is why we have so many muscles running around the foot and so many muscles running around the hand. Because hand precision, prehension, foot weight bearing, stance, swing, propulsion, सब कुछ करना चाहिए इसको. So it is very, very important component. CPU, remember CPU. CPU is without the talus, peanut talus, because talus forms a unit along with the ankle joint. Clear? Is it clear? I want to be sound in the basics because you have to remember what I have told you even after 10 years. Okay? Clear? Until you die. Okay? This tibialis posterior muscle, I told you about the insertion component, right? So I told you how it overcomes, the nature of the tendon, how long it is, how many centimeters is divided of net surface, that is what is given here. Okay? So please, I'll give you 5 seconds. Please go through it. Just 5 seconds. Please read it. Done? Are you done? इसको भी पढ़ना anatomy. Done? कुछ अंदर गया? नहीं तो सिर्फ बारी अंदर गया ना? ठीक है, very good, thank you. I told you we initiate the plantar flexion. It is the initiator of the inversion. Okay, please go through. Visualize. So whenever we are listening to something, you should have 3 types of orientation. Number 1 is visual orientation, spatial orientation, auditory orientation. All these 3 things should be there. Okay. So I am trying to provide what all I know to my little knowledge to you people. I want you to share your knowledge also because I am a everyday learner. I learn from my students. They are the teachers for me. Okay. So please read it. Enjoy the session. अगर कोई दिक्कत है तो हाथ उठाकर बता देना. ठीक है. See here how fantastic the foot component is. So you can see the transverse dorsal locking mechanism. You can see the forefoot, you can see the navicle, you can see the cuboid, you can see the talus, you can see the calcaneum. Now it is neatly arranged, right? Just like a Qutub Minar, inverted Qutub Minar. Okay? How uniquely it's arranged. Imagine something happens to the navicle. Navicle is not able to hold it. The hinge, we call it as a hinge, okay, like a door, okay. Same thing is happening to the navicle. Navicle, I told you, right? Posterior tibial tendon, PTTI. Posterior tibial tendon. Physiotherapist PT should know PTTI. Okay, clear? So see how it's fantastically arranged. When there is a deficiency or insufficiency of the tendon, you see how the hinges is moving away. It is not in coordination. It gets altered, it gets hindered. Okay, clear? So these are the functions along with the gastrocsoleus. You can see how fantastically it moves. The powerful inverter. Gastrocnemius is a powerful inverter because it does a plantar flexion. It's a powerful plantar flexion and it also is a powerful inverter. It is augmented by the most powerful muscle of the inversion, which is posterior tibial tendon. Okay, clear? So you should correlate. Gastrocnemius ka power we have to see. Posterior tibial tendon ka power we have to see. Both things are very, very important. Okay. If you are knowing about what I am taking you for 30 minutes here, you are the master of foot anatomy. I say, I bet you. You will be the master. You can teach me. Okay? So please, the answer is no. Okay. So here it says unable to, when there is a deficiency or insufficiency, it is unable to do an inversion. The simple method is ask the patient to stand on his heel by raising the heel, toes. Stand on the toes. He will not be able to do. The patient will not be able to do this himself. Okay? Yeah. So it will be either painful or it will be insufficient and there is a deficiency of the posterior tibial tendon. Okay? People on the left, Adhukana. People in the middle, Adhukana. People on the right, Upar, Bhagwan. Upar, Bhagwan. सब लोग भगवान है, ठीक है? Right. So we should know the effect and the cause. Effect and the cause. It's very, very important. The cause effect is very important to correlate. Okay. So we have to know the etiology, we have to know the goal of treating the condition, we have to know the pathology. I told you the pathology, right? Clear? Navicle, talked about the posterior tibial tendon, talked about the gastrocnemius, and one more interesting component is there in the navicle. That condition is called as accessory navicularis. Accessory navicularis. So everybody knows about the ossification, right? So during birth, there will be multiple components on the bone, especially around two components. So what will happen? It has to unite. In certain people, the navicle will not unite. It will be in two pieces. It will be in two pieces in the adult. So what will happen? The navicle will drop down. One component of the navicle will drop down. So that will lead to congenital flat foot. Okay. The reason for the congenital flat foot, accessory navicularis, is very, very important. It can be easily identified and diagnosed by taking a simple radiograph. Nothing else. Take a simple radiograph, it's easily identifiable. Okay. And it is a very important component of the talotarsal mechanism. Talotarsal mechanism. Talus belongs to ankle, tarsal belongs to the other components. Okay? So what is the movement of the ankle? Anyone? Please. Ankle ka movement. I need someone to please pass on the mic, please. The hands-free mic. We have a hands-free mic. What are the movements of the ankle?
Eversion. Eversion or inversion?
Sorry, it doesn't belong to the ankle. Inversion and eversion belongs to subtalar joints. It belongs to subtalar joint. Ankle ka movement, dorsiflexion, plantar flexion. Okay? I know, as a student, I too had the same confusion, so nothing wrong in it. So please remember, the movement of ankle is just plantar flexion and dorsiflexion. Inversion and eversion, ankle में मत लेकर आना. Inversion, eversion belongs to subtalar joints. Clear? Will you remember? You teach to others also. Okay, you just tell them. Ankle just in plantar flexion and dorsiflexion. Inversion aversion belongs to subtalar joint. Okay, Ullamal. Okay. Right. Now I will want you to do one simple activity. It will just take 1 minute. Okay. All of you just look at your hand and your palm. Okay. Everyone, please, everyone. So you can see a palmar crease in the wrist, right? There is a line, transverse line, right? Dono haath mein hoga. You try to equal it. So that it forms a single line. Both the hands. Okay? Now close it. First equal it. Both the lines should be in the same alignment. Okay? Then close it. Now look at the middle finger. One of the middle finger will be taller than the other finger. Yes? Yes? Everybody? Yes? One of the middle finger will be taller than the other finger. Okay? Now, what I want you to do is, please clap your hands for 2 minutes. Please clap your hands for 2 minutes. Jodhar. Also, so, काफी है ये गैस उड़ गया क्या ओके Jodhar ऊपर okay relax now take both the palms together and match both the lines okay आपको एक उंगली higher है ना आपको मालूम है either right or left ठीक है now try to close it equal हो गया सब लोग equal है ठीक है simple concept okay clear now has the figure is not equal nothing is higher than the other one so nobody is higher than anyone all are equal वही तो physiotherapy का मंत्र है that is why I am here I have reached this position because I have been treated equally by my seniors, I have been treated equally by my teachers, I have been treated equally by my juniors, by my students. Okay? Clear? Right. So like this, you have to concentrate on your studies. No study is beyond your knowledge. You have to study to make it equal to your knowledge. ठीक है? बात सीधा? Yes. Thank you. Out. This is the normal talotarsal mechanism. Okay, you can see how comfortably the talus sits on the calcaneum, and you can see the sinusoid line running very fine and very genuinely causing a very good alignment. Okay, the people who are having eversion will result in flat foot. उसका gait कैसा होगा? उसका जो posture, उसका जो alignment कैसा होगा? So they will be feeling more inferior. That's the first thing. Okay? Especially females. Whenever the females are having the medial arch reduced, their gait will change. Their posture will change. Their lordosis will increase. There will be a knock knee. Then boxer will go for valor. They will not be confident. So we have to make them confident. How? By our hands. We are the artists. Okay? Always be the artist. Don't be the paint. You know why? Because paint इधर से लेकर इधर रखा तो इधर होगा, इधर से लेकर इधर रखा तो इधर होगा. मगर artist will decide where the paint should be. So you should be the artist. Okay? Clear? So next you can see how the substernum tali is broken and how the alignment is distorted and how the foot is going into abnormal posture and the osseous alignment is completely disturbed. Right? So you can see here, the navicle is dropping down. The cuboid is dropping down. Okay? Clear? So the normal posture is affected. The gait is affected. Confidence of the person will be affected. Okay? Clear? So this is what the unit I was telling about the CPU, calcaneum pedal unit. Please read it. I'll give you 5 seconds. Finish? एक और 5 सेकंड चाहिए finish right this is the alignment of the CPU I told you 3 orientation visual spatial auditory. So I am giving a auditory orientation by talking to you. I am making you feel present in this environment. I am giving you the visual field to concentrate. Please combine all these three. Equilateral triangle. Okay? Equilateral triangle. All should be equal. Okay? So spatial orientation, auditory orientation, visual orientation. Please store it in your brain. Okay? So you see there are so many ligaments, especially the bifurcate ligaments, very, very important. And the plantar calcaneoangular ligament, which is a spring ligament, it is very, very important for maintaining the medial arch. Even this point I have told you earlier. Please look at the slide and rewind and review what I have told you earlier. Okay? I want you to be more interactive with me, not among yourself.